Indigenous Children's Physical and Mental Health by Sheila Nikashi. The outline: glossary of terms, trauma, brain development, trauma exposure on child development, intergenerational impact, housing and health, mothers abused by intimate partners, failure to protect stories, the partner, parenting after trauma case study. The glossary in terms: trauma, exposure to actual or threatened death, serious injury or violence in one of the following ways: direct experience, witnesses of traumatic event, learning that a loved one experienced trauma, repeated or extreme exposure to adverse details of traumatic events. Example of child welfare authorities who develop secondary traumatic stress after repeated exposure of their clients' trauma stories. Child trauma stress occurs when a child experiences a traumatic event or situation that upsets and overwhelms his or her ability to cope, and the signs and symptoms interfere with the child's daily life. The body's alarm system function of the brain that scans the environment and for potential danger and prepares us to act. When triggered, the alarm system sets off a cascade of immediate psychological changes that prepare one for fight, flight, freeze response in order to stay safe. This is a complex response that involves multiple areas of the brain, including the systematic nervous system and the amygdala. Trigger: a reminder of the past triggered events that sets off the body's alarm system so that the person feels in imminent danger once again. A trigger can be anything connected to a traumatic event, including an event, situation, place, physical situation, or even a person. Post-traumatic stress disorder is a mental health disorder most commonly associated with trauma exposure of PTSD. Is characterized by problems in 4 areas: re-experiencing, example, flashbacks or nightmares or traumatic events, avoiding of thoughts or reminders of past trauma, negative changes in thought or mood, example, persistence negative emotions, persistence of exaggerated negative beliefs about oneself, others, and the world, and hyperarousal, anger outburst, being constantly on guard against potential threats. Some people may also experience this association. Complex trauma refers to the exposure of multiple and prolonged forms of trauma experienced in childhood and a wide-ranging long-term impact of this exposure. Complex trauma disrupts normal child development and may lead to difficulties with attachment, ability to form trusting, meaningful relationships, managing emotions and behavior, and exclusive functioning. Example, ability to focus attention, solve problems, plan, or pursue long-term goals. Kinship foster care refers to the placement of youth in foster care that is provided by grandparents, aunts, uncles, and other family members. Fictive kin, individuals who played an important role in the youth's life but are not related through marriage or birth. Dual system, involved youth refers to youth who are involved in both the child welfare and juvenile justice systems. Psychological safety, the belief that one is safe from emotional harm and has the ability to manage threats to safety. Psychologically, self-environments encourage respect for others' feelings even when there is disagreement. Individuals can also increase their own sense of psychological safe in stressful situations by learning and using coping skills. Dual system involved youth involved in both the child welfare and juvenile justice system. Complex developmental trauma is when children in care experience systems and difficulties associated with complex trauma. It refers to the impact of children's exposure to traumatic events on their development and long-term outcomes in the complex of interpersonal relationship with caregivers. The neurological development of the brain becomes distorted, such that the survival mechanism of the brain and body are more dominant than the learning mechanism, resulting in wide-ranging impairments in arousal, cognitive, emotional, and social functioning. Researchers have yet to develop ways to define and measure complex trauma so that an evidence base for intervention can be established. Neurosequential model, one popular description of the impact of early adversity and complex trauma in the context of neglect and abuse, links these environmental events to chronic disruptive of the child's stress hormones, leading a chronic hyperarousal and ongoing sensitivity to stress. Chronic stress hormone dysregulation is thought to lead to changes in the sequential development of brain structures and brain functioning through the process of use-dependent sympathetic pruning. These changes may be addressed, at least in part, by regular and intensive intervention that regulates the more permanent regions of the brain through repetitive and rheumatic activities in the complex of continuous therapeutic relationships. Specific cognitive difficulties and suggestions interventions for children in neurodevelopment difficulties suggest that it's beneficial to develop specific approaches to address each difficulty. Example, building memory, attention, or language skills. Separately, specific difficulties together and target strategies for their intervention. General delays in language acquisition, language delays in developing speech and vocabulary mean that affected children may struggle with verbally mediated counseling approaches that rely on oral language competence, such as narrative therapy and restorative justice approaches. Children with beneficial use of simple language, repetition of key concepts, visual strategies, cartoon social stories, and visual prompts to support the uptake of ideas from therapy or discussions with caregivers. Specific cognitive difficulties and suggestion interventions. Difficulty with cognitive flexibility means that children may struggle with the adapting ability to suit different settings, to transition from task to task and to plan, initiate or complete school work. Children with this kind of difficulty may benefit from highly structured environments where expectations are clear. They can benefit from prompts to stay task and use the prearranged strategies to let them know when a transition is pending. These can include advanced warnings using timers and visual clues. Example, paper chain links or a timer to count down to the end of an activity. Difficulty in behavior regulations and impulse control may be supported by learning and rehearsing stop, think, do strategies and by the use of prompts to remind the child to monitor their behavior. Example, snapping elastic band around the wrist and to act as a stop gag between impulsive and action. Visual clues and reminders of the steps between impulse and actions can also be helpful. Specific cognitive difficulties and suggestions interventions. Difficulty in emotional regulation. Children in care can experience a range of difficulties related to the ability to identify, recognize, experience, tolerate, and appropriately express emotions. Depending on the difficulty, children can benefit from training in the recognition of emotions and support when learning the name of increasingly complex emotions to increase their emotional literacy. Positive role modeling is also an important means by which children can learn socially acceptable ways to experience emotions. Children who have experienced trauma may have difficulty in fully experiencing some emotions, and providing an environment in which the child can begin to safely experience these emotions will be helpful. If caregivers can tolerate trauma-related emotions, then children can learn that it is safe to express these emotions over time. Interventions such as dialectical behavioral therapy that support children and adolescents to tolerate strong emotions are helpful and can lead to improvement in self-control over time. Specific cognitive difficulties and suggestions interventions. Difficulty in paying attention and reminding children with these difficulties may appear as though they are not complying with instructions or that they are being willfully disobedient. Caregivers may need assistance in adapting the way that they give instructions and make requests to children. Caregivers may need support with strategies to gain children's attention prior to engaging in conversation. Rehearsal and repetition techniques can improve the child's difficulties in attention short-term memory. Verbal memory can be strengthened by instructing children and caregivers in the use of written reminders, cue sheets, diaries, and electronic reminders, phone alarms, for example. Computerized programs have been shown to improve memory and attention skills in clinical populations. Specific cognitive difficulties, changing the social information processing. Children's automatic reaction to social stimuli is likely to be biased towards fear or hostility. Caregivers can support children in reappraising social situations by teaching and modeling the appropriate reactions to social situations, conveying trust in other adults, and modeling appropriate social interaction skills. Children can sometimes display poor social discrimination, leading to poor choices regarding social interactions. Appropriate social boundaries can be reinforced using visual teaching aids such as circle diagrams that can be used to distinguish family from non-family and friends from strangers. There is also some evidence that computerized programs against target social anxiety may be helpful in addressing eye contact aversion in children and adults. Heightening arousal, alterations in consciousness, and introversive imagery. Children can experience PTSD symptoms following distinct traumas in which sensory information and emotions become disconnected. Later, reminders of trauma can cause fragments of the memory and sensation associated with the trauma to be re-experienced out of context. Example, flashbacks, nightmares. Children may learn to avoid reminders of traumatic events in the attempt to avoid experiencing unpleasant emotions associated with the trauma. PTSD symptoms can be minimized by providing the opportunity for children to talk about unpleasant events, thoughts, and feelings. Heightened arousal, alterations in consciousness, and intrusive imagery. In trauma therapy, children are encouraged to learn to recognize and tolerate the strong emotions associated with trauma, and this helps minimize avoidance and some symptoms over time. Children can find it reassuring to know that an adult can tolerate their strong emotions without becoming overwhelmed. Relaxation training and mindfulness strategies can also be helpful to calm, heighten arousal, and in learning to tolerate strong feelings associated with past events. Specific sleep hygiene strategies may also be needed due to heightening arousal interfering with sleep-wake cycles. Examples support with learning bedtime routines and nighttime wakening. Trauma exposure on child development. Approximately 90% of the parents or caregivers involved with the child welfare system have histories of trauma exposures, including high rates of childhood abuse and neglect, and a significant number were involved in the system as children. Families may be affected by historical trauma resulting from societal racism, oppression towards ethnic minorities, particularly African American, Native American, and immigrant communities. The impact of these traumatic experiences on both caregivers and their children can be inadvertently intensified by institutional practices within systems such as child welfare or juvenile justice. Exposure to trauma does not always determine adverse outcomes for parents and their children. For some parents, prior trauma exposure may negatively impact the manner in which they interact with their children, thereby placing children at higher risk for traumatic stress. This is also known as intergenerational trauma. For example, parents with histories of repeated exposure of violence may have a greater difficulty recognizing the adverse effects of violence exposure for children. Untreated PTSD can also interfere with the patient's ability to use safe and effective parenting strategies and protect their children from abuse by others. In turn, without effective intervention, children exposed to negative or abuse are significantly more likely to perpetrate violence against dating partners, enter into abusive relationships in adolescence and adulthood, and perpetrate abuse of their own children when they become parents. Addressing traumatic stresses within families in the child welfare system is essential for reducing rates of child maltreatment and interrupting the intergenerational transmissions of trauma. Recognition of these risks can position authorities to recommend resources to clients that lessen the impact of risk and bolsters clients' resilience. Parents with traumatic history who abuse or neglect their children may view their parenting behavior as normal and may not understand that there are alternative ways of interacting with children. A traumatized parent may be hyper-vigilant or overly focused on identifying potential threats to his or her child. Hypervigilant parents may react harshly to child misbehavior because they fear consequences or reactions from others if their children continue to misbehave. Parents with trauma history may also place extreme restrictions on their children, such as requiring them to spend all free time at home and to avoid potential danger. Trauma can be depleted to parents' psychological and physical energy, as well as the financial and social resources necessary to accomplish parenting tasks. Family when residential school attendance is shown to affect directly all 5 health and mental health outcomes and is associated with lower self-perceived health and mental health and a higher risk for distress and suicidal behaviors. Odds of being in lower self-perceived health remain statistically significantly high with the percent of family attending residential school. The odds of having had a suicide attempt within the past 12 months remain twice as high for those with family attending residential school. Biological research in the area of the epigenetics have shed light on potential mechanisms of intergenerational transfer of parenting experience in the health and well-being of children. The effective experience of a parent on a child or grandchild may be linked through epigenetic inheritance. Epigenetic inheritance refers to modifications in gene expression in parental cells in response to challenges presented by the environment, which can be transmitted to a child, F1, first, and at least another generation or two, F2, F3, in the absence of the original exposure. Studies have shown that early life experience has potential to alter DNA methylation states without changing DNA sequence. Intergenerational impact. The epigenetic modification can lead to lifelong changes in the hypothalamic pituitary adrenal HPA response to stress in children based on the experience of parents or grandparents. Trauma stressors may have been shown to alter HPA axis functioning such that coping biologically and behaviorally to subsequent stressful events becomes exaggerated. Epigenetic modifications have been shown to have long-lasting stability behavioral responses that can express the length of the stimulus and when maladaptive can result in psychiatric disorders. Transmission of the parent experience and coping skills can explain how even before conception, environmental exposure of parents is a determinant of risk and coping in the following generations. Psychosocial. Biological mechanisms also potentially inform the psychosocial coping abilities in the environmental individuals as they move through the life course. Children survivors of traumatic experience who themselves experienced trauma were shown to be significantly more likely than controls to develop post-traumatic stress disorder. Even traumatic stressors experienced early in childhood of a parent may influence their children's well-being. Attachment theory provides a theoretical construction of psychological that can explain the transmission of health and pathology from parent to child via role modeling and relation type, respectively. Attachment theory suggests that the parent-child bond is biologically based and essential for survival of the child. This bond develops into an attachment style that is shaped in early childhood and is apparent throughout the life course. Insecure attachment between parent and child is systematized by pathologification, rejection, fear, and unresolved trauma has been found to be highly prevalent. 83% in children whose parents were subjected to childhood trauma. Maternal experience of childhood trauma mediated by maternal mental health has been shown to be a significant predicator of child health and mental health outcomes and a maternal experience of high betrayal trauma. To the level of perceived intervention by her own parents was shown to be the only significant predicator of her own parent attachment style with her infant child. A mother's exposure to abuse in childhood is significantly associated with poor mental health outcomes, which influences parenting style and is associated with children internalizing depressive symptoms in early childhood. Parenting experience of trauma in childhood and its impact on childhood's broader access to social and community supports can be understood through a phenomenon of silencing, or the conspiracy of silence. In the Holocaust survivors of the children, whereby children were verbally or non-verbally taught not to trust anyone and not to communicate about their experiences. Conversely, compulsive retelling the traumatic experience by parents to their children may cause vicarious trauma of children as well as student children to parentification or other non-childlike roles without the family that cause undue stress. The abduction of Indigenous Canadian children from their homes potentially impacted on parenting skills and styles. In addition, being separated from their families of origin, residential school survivors exposed to abuse and neglect in the residential school environment has maintained in the transmission of abusive neglect parenting patterns into the Indigenous communities. Across all cultures, when the individual is abused or neglected in childhood, that person's propensity to abuse or neglect their children is significantly higher. Coping with traumatic experience has been shown to include the use of harmful substances such as alcohol and drugs, in addition to populations and in populations suffering from PTSD more broadly. Health behaviors, which have more direct impact on health outcomes, are shaped by biological, psychological, and social factors. The First Nations Information Government Center provides descriptive statistics provided by the Regional Health Survey regarding on-reserve First Nation peoples and variety of the SDH outcomes, including health behaviors. Statistics from the RHA describe poor health outcomes in survivors and children of survivors of the RS. Community. For individuals with ancestral residential school attendance, separation from family, stress from trauma events in the past, and current community stressors both mediate and are indicators of the pathways and impacts of a distilled trauma on current generations' health and mental health. Those directly exposed to one or multiple policies impacting cultural loss, residential school, geographical relocation, child removal, cope as individuals as well as in the context of the community settings. Indirect effects on individuals who attended residential school may be influenced by others in their setting scope and the prevalence of prior generational exposure to residential school attendance. The first generation following attendees may experience direct biological and social transmission of the parenting coping experience, as well as indirect effects determined by environmental exposures and coping. Grandchildren of attendees experience indirect biological and social exposure, as well as direct social exposure to family dynamics and relationships that may be impacted by grandparent attendance. Possible mechanism for the intergenerational transfer of trauma. Relationship of interest. The ancestral attendance of the residential school impacts on current generations of health and mental health. Plausible mechanisms, biological pathways, examples, genetic changes such as HPA, axis arousal, coping, stability, maladaptation. In the psychosocial pathways, parenting, trauma-based symptoms, isolation, community pathways, oppressive, cultural discontinuity, and structural resources. Housing and health. This study used in 2006 Aboriginal Children's Survey to examine the relationships between housing and psychological and mental health for First Nations preschool-aged children living off reserve. The study provides evidence that physical, spatial, and psychological aspects of housing in which youth off reserve First Nations children live are associated with their physical and mental health, even after controlling for family socioeconomic factors, area of residence, and child's age and sex analyzed with regression models. The investigation of the relationship between housing and health. Three dimensions of housing are considered important: material dimensions, spatial dimensions, psychological dimensions. Material dimensions include psychological aspects such as indoor air pollution from molds and conditions of the building, such as whether it is need to major repair or whether there is a smoker in the home. Material dimensions also include financial aspects of housing, such as whether housing is affordable and also whether it is owned by a member of the household. Second, spatial dimensions include both housing suitability, including crowding, and the surrounding environment, including the neighbor. Included in the spatial dimensions are how long a child stays in the same residence or how frequently he or she moves. Psychological dimensions of the house, including the sense of control a person feels regarding his or her housing, as well as satisfied a person is with his or her housing. Psychological dimension of housing is related to the material and spatial dimensions such as how home ownership, crowding, and neighborhood safety can affect a person's sense of control. All of the above aspects of the housing have been associated with a child's health in the general population. In terms of the material aspects, people who live in the houses that are damp, moldy, or in houses where people smoke are more likely to have respiratory conditions, asthma, allergies, bronchitis, etc. Some houses may present conditions that could cause injuries, such as loose window screens and poor overall construction. Home ownership has been associated with better general physical and mental health and also in fewer behavior problems in children. Providing living in crowded homes are more likely to have respiratory conditions, to have infectious diseases, and to have worse health overall. Some research has also found that people living in crowded homes have worse mental health, although the evidence is mixed. Frequent moves have been associated with behavioral and emotional problems in school-aged children. Lastly, in terms of psychological aspects, classification with the housing conditions has been associated with better general physical and mental health. Analysts for housing and family social demographic characteristics were examined for off-reserve First Nations and non-Aboriginal children 2 to 5 years old. Regression analyses were conducted separately for each child: physical health outcomes, parent-related child health, 2 or more ear infections in the past 12 months, activity limitation, persistence of 2 or more chronic conditions, chronic respiratory conditions, serious injury in last year, and mental health outcomes, pro-social behavior, hyperactivity, inattention, emotional symptoms, and conductive problems. 5 models are examined. Model 1 include the material aspects of the house. House is needed to major repair, unaffordable house, home ownership status, and regular smoker in the home. Model 2 examined the aspects of the housing. Crowded household, 1 or more moves per year. Model 3 examined the psychological aspect of the housing, parenting satisfaction with the housing condition. Model 4 included all aspects of housing examined in the previous 3 models. Model 5 included all housing factors along with social demographic variables to examine and assess the association of housing conditions with child health over and above family level SES characteristics. Mothers abused by intimate partner. Children exposed to intimate partner violence. Researchers linked children who were exposed to IPV to trauma responses such as post-trauma stress disorder, to internalized problems such as depression, low self-esteem, and withdrawal, and to externalized problems such as aggression and hyperactivity. Critics of this early body research noted limitations such as problematic definitions of CEDV and not distinguishing between children who have also been physically or sexually abused by the IPV perpetrator from children who were only exposed to IPV. Almost all studies that identified harmful effects also found some children are resilient. Other researchers identified protective factors for children such as personal coping skills, temperamental extended social networks, and warm mothering. Nevertheless, the needs of children who are negatively affected must not be ignored. Assessing children on a wide range of factors and with knowing of the unique dynamics of IPP is important. The mental health measures mothers and children in care reported significantly more psychological distress in the clinical range and lower quality of life, perhaps not surprising with their lower incomes. As mentioned previously, it is unclear if the mother's mental health distress was the result of the violence perpetrated against them or having had their children taken into care, or both. Failure to protect. Telling the stories of the Indigenous youth harmful by the failure to protect policies. These examples offer evidence for the failure to protect clause in legislation and differential approach with government is identified as a child's parent that is unwilling or unable to protect the child versus when Indigenous women are. In 2002, Sherry Charlie, a 19-month-old First Nation toddler, was murdered by George, a First Nations male 25 Native social work journal following to protect and provide in the best place on earth. Can Indigenous children in Canada be safe if their mothers aren't? Caregiver under contact in the BC child protection system to provide care to the toddler and her 3-year-old brother. George had a violent criminal record and his rages left the toddler dead of 11 broken ribs, severe bruising, and was in various stages of healing and 3 blows to her head. Both the paramedic that attended the scene and pediatric physician at the local hospital suspected that the caregiver's explanation that Sherry was pushed down the stairs by her 3-year-old brother did not ring true. However, they did not report their suspicions to the BC Child Protection authorities. Despite the pathologist reporting established that Sherry was battered child, 4 months from the time of her death passed before police launched an investigation. For a total of 5 months, the BC Child Protection System would leave Sherry's 3-year-old brother in the care of the real murderer. Angry and outraged and injustice against Sherry, her brother and parents' family members moved me to suggest that the family retained legal counsel to represent them at the February 2006 inquest into Sherry's murder. I question if the systematic inaction would be tolerated if Sherry had been a Caucasian child from a middle or upper class family rather than First Nations toddler from a poor family. Disturbing information provided by the Indigenous research participants indicate that the times the BC government failed to protect Indigenous youth in its care, sometimes even with full knowledge that harm was likely to occur to children in its upper resources. Stories testify that the times of government care subjected Indigenous children to witness violence against foster mothers by their spouses, experienced vicarious abuse, violence by older youth in the child protection system and by fellow students. As a result, these Indigenous youth were further traumatized, not safe, or removed by abusive non-Aboriginal foster placements for months or years, lacked advocacy and oversight bodies, and had limited access to culturally relevant counseling, support, or safety to recover from the violence witnessed or experienced. I saw something and I went into the cabin to see. Hey, Mom, Dad, did you see? And he just hit her foster mother. And her glasses were on the floor. Telling a story of Indigenous youth harmed by a failure to protect policies. I didn't know what to do. I wanted to jump off the boat. I didn't want to talk to either of them. There was violence. It would make me go inwards. I became very silent, closed. We went through some abuse. We sued the first foster home I was in. They called it vicarious abuse because they had 2 older kids in the home and they were my abusers. They called it vicarious abuse because the foster father had been abusing the older kids. Came out in the trial that those foster parents had previously lived in Alberta, and the Alberta government was so horrified by the way they had taken care of the kids that they sent a letter to BC saying, do not allow these people to be foster parents. Telling the stories of Indigenous youth harmed by the failure to protect policies which they ignored because they needed foster parents. The story was that the mom stabbed one of the foster kids, and I think they were giving them Valium as well. One of your questions was, did the social worker ever come to visit you? It wasn't even a social worker that dropped us off at the foster home. It was the receptionist that came out in the court. Overview of knowledge about trauma and its impact about parenting along several dimensions. Parenting after trauma. How trauma experienced by parents, example, direct violence to parents or violence in their communities, affects their functional ability to parent. How parents are impacted by their child's own experiences of trauma. How children are then influenced by the impact of trauma on their parents. Clinical case study that provides the overlapping and interrelated clinical needs of families experiencing trauma. The authors describe further the mechanism of which the parenting relationship can affect the adaptation to trauma. The 4 types of effects are defined: minimal, in which the child is not notably affected by the traumatic event; mediating, in which, based on text, the child is not directly impacted by the event, but rather by the mother's own traumatization; moderating, in which the mother's response to the child's aspects of the child's outcome; and combining, in which both parents and child are traumatized and the emotional adaptation of each exaggerates that of each other. Parenting after trauma, development considerations for youth traumatized children. Infants and toddlers who witness either violence in their homes or violent incident in their community show increased irritability, immature behavior, sleep disturbances, emotional distress and crying, fears of being alone, physical complaints, and loss of skills such as regression in toileting and language. Temporary traumas and clinging manifest in an ability to separate from parents or family caregivers are common. Exposure to trauma, especially in violence that impacts directly on the family, interferes with the young child's normal development or trust and later exploratory behaviors that support the development of autonomy. When young children are severely traumatized, the symptoms noted are similar to post-traumatic stress disorder in adults, including repeated re-experiencing a trauma event, avoidance, numbing of responsiveness, and increased arousal. For example, these young children are often afraid to be near the scene of a violence, even when they are witnessed, are afraid to go to sleep or wake up with nightmares, and show a numbing of restricted range of effect after then a range of emotional in their play. They commonly appear very serious and even spacey or disorganized at times and smile very little. Preschool children exposed to violence are less likely to explore and play freely, showing less motivations to master their environment. Again, it is important to note that for very young children, the severity of their reactions, of their ability to cope with the trauma is affected significantly by their parent and caregiver's response to the trauma. A history impacts child and parenting function. Case study. John is a bright, engaging, high active 3-year, 6-month-old Caucasian boy who lives alone with his mother. John was referred to a violence intervention program for children and families because of his extensive aggressive behavior at home and at the child care center he attended. John and his mother were initially interviewed by a social worker, supervising a psychologist and psychiatrist to assist prior development, psychosocial trauma, and medical history, as well as the current family and mental health functioning. Observations of parent-child interactions also were used to assess relationship strengths and difficulties. At the age of 3, John already had been expelled from 2 child care centers because of his unmanageable physical aggression with peers and teachers, example, hitting, slapping, kicking, biting, pinching. His mother, Miss C, was concerned about this aggressive behavior at home, reporting that when he was angry with her, he would scratch and even attempt to strangle her. His temper tantrums were frequently uncontrollable. These behaviors frightened John's mother, and she did not know how to manage them. Furthermore, John showed severe separation anxiety, including screaming and holding his breath whenever she attempted to leave him. His anxiety seemed to carry over to nightmare behaviors when John reportedly had difficulty sleeping, frequent nightmares, and night terrors. John's current behavior with his mother's current stresses seemed to be taking a toll on her ability to confidence in parenting. John's mother was feeling at her wits' end and unable to manage her own stress as well as her child's growing problems. In assessment of the parental anxiety administered during the assessment phase, John's mother reported an extreme high stress level as a parent. She had lost several jobs when John was expelled from school care centers and had little family support to help with her child. Moreover, observation of parent-child interactions revealed numerous difficulties and challenges for this dyad, including lack of shared joy and affect, minimal structure in play, lacking of limit setting, a low frustration tolerance for mother and child. A thorough assessment of trauma history revealed that John and his mother had a long history of violence exposure. Miss C also had a quick base of text and violent temper. John often witnessed family and partner violence experienced by his mother. In one instance, he was in his mother's arms when his biological father shot at her. Although neither John nor his mother were shot in this incident, both were treated for cuts and bruises, which John was permanently scarred. John was also present when his mother attacked an acquaintance. His mother also reported to have witnessed numerous fights and stabbings in the neighborhood. Further psychosocial assessment indicated numerous losses of a history of family mental health problems. In addition to the long history of violence exposure, John and his mother experienced many significant losses, including the sudden death of John's biological father, who was shot during a robbery, as well as an incarnation of his mother's current partner. Miss C's childhood had been filled with loss and difficulties, including having to raise herself due to her own mother's severe mental illness, experience repeated foster placements, and having no father figure. It became clear that neither John nor his mother had yet worked through many of these losses and frightening experiences. Misty reported that she had a history of untreated depression, trouble concentrating, difficulty sleeping and eating. She appeared hypervigilant and very anxious during the assessment. She was unable to give a clear and consistent history due to intrusive thoughts and persistent fears. Missy's story about their life together revealed her fears about continuing danger and violence in her life, little support and recognition that this violence might be impacting her young son. Yet, her prolonged history of violence and loss appeared to leave her unavailable to her son emotionally and unable to break the pattern of experiencing endangering and frightening situations for herself and her son.